records, record here. All right, great. All right, Nii, thank you so much for being with us tonight.
Hey, Dr. Ian, I'm excited to be here. I've been a longtime listener to the show, so it's really good to be a participant of your show. So thank you.
Yeah, we're so excited. The team is very excited to have you on. And there's so many places that I want to go and so many things I want to talk to you about. And usually we ask about what somebody's day looks like, but I want to start off talking a little bit about Docs Outside the Box and your podcast, which I'm a regular listener of your podcast. So can you tell us a little bit about how you got interested in podcasting and how you came up with the idea for the podcast, and maybe a little bit about maybe what the mission statement of or the mission of your podcast is, and why you're doing it.
Yeah, very easy. We started the podcast, or at least I started the podcast because I was broke and I didn't know what to do with my career, so to speak, to be very honest with you. If you asked me in 2016 when I started it, I would tell you that I wanted to hear stories of people who were doing some really interesting things outside of medicine. But the real reason, looking back, was I was broke. I didn't know how to get out of debt. And I also was really fascinated with some of my colleagues who were doing some very successful things outside of clinical medicine. And I was looking around on, my podcast directories. I was looking around on in YouTube, and I didn't find anybody who was featuring these type of stories. Everything that was out there was just, okay, well, once you graduate from whatever training that you're going to do, you're going to get a job, and that is it. And I was really at a crossroads early in my career. And between me and my wife, we had close to about $700,000 of student loan debt. I also had an apartment that I became an accidental landlord that was around 175,000. My wife had some IRS debt. She was on a lam from the IRS. We joke around about that, but she really did owe the IRS some money. So we literally had about $850,000 of debt. And I don't know about you, I don't know about the listeners in the show, but when I wanted to become a doctor when I was growing up in Queens and also growing up in across the river in New Jersey, the last thing that I was thinking about is that when I finished this journey, that I would be close to $1 million in debt, and that was a major problem for me. So I just started listening to podcasts. I started reading blogs, and go back to where I was saying there really wasn't any stories about someone telling a story about paying off debt, as well as featuring docs who were just really thriving in fields outside of just traditional clinical medicine. So I just said, let's go ahead and just start this and see what happens. And at first my mama was the only person listening and downloading it. And I had some of my friends who I would grab their phones and say, hey, listen, man, download my episode. And then, after a while, it just started to catch on. And it's really become this thing where it's a part of me. It's a part of my wife's fabric. If nobody listened from now until, the end of time, we would still be podcasting because we enjoy it that much.
No, I enjoy listening to you, and I think you and your wife have such a nice relationship and such a nice dynamic between the two of you. It's great to listen, and I would highly recommend that anybody listening to us today check out Docs Outside the Box, because I just think it's awesome.
Appreciate that. Thank you very much.
Yeah, Nee. So can you tell us, next, maybe tell us a little bit. We're going to go back to what we usually do and just tell us what your normal day looks like. And can you tell us, at the same time, I know you do locum work
Yeah.
mainly. So maybe, some of our listeners don't even know what locum is. So maybe you could tell us what a normal day looks like, if there is a normal day, and what a locum career looks like.
Yeah. So in 2017, I went 100% full-time locums. So what locums is, or locum tenens is, it's Latin for placeholder. So just like if you can think of any type of business that has a temp, that hires a temp agency for a secretary or for someone who can fill in for somebody else, the same thing happens in hospitals, mainly in rural as well as suburban areas. And that's what I like to do. I like to work in a fashion where maybe I have a contract with the hospital and I'm working there. I'm not employed by them, but I'm working with them for maybe 3 months, 6 months, sometimes a year. The most One of the hospitals that I'm working with right now, I've been working there for about 3 years. And I like that type of experience for me because it allows me to, work really hard as a trauma surgeon. And then also at the same time, it allows me to kind of just sign off. And then I'm away from the hospital and I get to stay away from like the geopolitical stuff that occurs when you are an employee. And not to say one is better than the other, it's just that that works for me. But when I work that way, I'm in charge of my taxes. I'm in charge of my health care. Depending on which hospital I go to, I'm in charge of my medical malpractice. I'm in charge of scheduling. But, over the last several years, I've gotten used to it. And it's something that I find very enriching. And it's as close to being an entrepreneur as I can get, I think, as a trauma surgeon. That works for me. Now, a typical day for me when I'm at most places is, I usually start my day. I'm up by 5 in the morning, and usually 5 in the morning, I'm doing some reading, some academic reading for surgical critical care or for, whatever I normally do. And then by the time I get to the hospital, it's roughly around 7 o'clock. And I will work from 7 a.m. to 7 p.m. And I am basically in charge of all of the surgical emergencies that you can think of. Oftentimes, I'll work with your specialty, Dr. Ian, working with GI. If someone has a really bad, GI bleed, sometimes I may have to take them to the operating room emergently. But more often, I'm taking care of people who have appendicitis, people who have, cholecystitis or an inflamed gallbladder, a small bowel obstruction, or someone who gets shot, stabbed, or in a car accident. And one of the things that I really enjoy about trauma surgery is I'm one of the few specialties where I can take care of someone from the ER literally all the way to discharge. So from the ER to the operating room to the intensive care unit if they need to, back to the floor, and then to discharge. So that's what I do from 7 a.m. to 7 p.m. I'm just handling all of those different things. I round on a patient. I may go to the operating room. I may go to clinic. Um, I may go to the operating room, like I said, and that's it. And then when I sign out to someone at 7 p.m., that person is going to work a 7 p.m. to 7 a.m. shift. Their job is to put out fires. If anybody needs emergent surgery, that's what they do. But for the most part, that's it. And then I go to bed, I sleep, I wake up, and I rinse, wash, and repeat, and I'll do that. And depending on where I'm at, I may do that for 1 week straight, like 7 days in a row, or sometimes I may do that for 14 days in a row. But as I've gotten a little bit older and I've gotten a 5-year-old and a 3-year-old, my wife has been very vocal of letting me know that I can't just be away for, 14 days straight. So I've had to learn to balance that. So now I'll do about 7 days straight. Otherwise, my kids kind of get a little antsy. And when I work like 5 hours away. So I stay in a hotel. I'm gone for 7 days. So she's taking the kids to school, she's getting them ready. And so it could be very tough. And then when I come home, I'm Dr. Dad, right? And I'll take like a week and a half off, usually like a week off, and then I'll go back and do an additional 7 days a week later, or maybe 3 days, and just try to make it work. The one thing that's really interesting about our career is that me and my wife have really said that, you know what, the most important thing is our family unit. So we have a rule where if I work, she doesn't work. If she works, I don't work. So she's a full time, or sorry, she's part time OB, and she oftentimes calls herself a stay at home OB, but she does work, and she'll do weekend call. And during that weekend, it's just me and the kids. And, we just want to make sure that we have like the kids have a continuous experience with a parent at home. So there is some sacrifice in terms of monetary, how much we really could bring in. But I think the investment that we're putting in with our family unit, with our kids, I think it's going to pay off long term. So that's like a typical clinical experience or clinical and hybrid home experience for me and my wife as well as for my kids.
It's so interesting. And I'll ask you, Nee, it's, from my perspective, I think a lot of times I'm a little sad that I'm not home. I have like a long day and I get home maybe 8 o'clock. I'm up at 4 a.m. I get home at 7 or 8 p.m. Maybe I see the kids for a couple hours and then I go to bed. And sometimes when I listen to your podcast and I listen to what you're doing, I think maybe I would be sad to be away, but
Mhm.
maybe you're actually spending more time with the kids and more quality time having that week off. Like, are you sad that week that you're away? And do you really make the most out of that week that you're home?
Yeah, so my wife always can tell when I miss her because literally like the first couple of days when I'm in a hotel, I'm calling her constantly, or I'm video FaceTiming with the kids and so forth. But I think for us, what we realized is once we got the debt out of the way, we are able to save a lot more of our money, and we're able to be a lot more frugal with our money. And that way we're able to take more chances in terms of saying, you know what, at this point in my life, as long as I'm keeping my caseload to what it needs to be to make sure that I'm staying as a competent surgeon, as long as I'm doing the things that I need to do, and same thing for my wife, that we'll sacrifice, not working all the time so that we can have some time with the kids. And I think, at least for the early parts of our kids' lives, I think once we get to like 10 and older, I think our kids are going to kind of float away from us. So right now it's just a little bit of a sacrifice, but also at the same time, this type of work style allows me to do the podcast. I'm gonna be very honest with you. There's
Hmm.
no way that, so roughly about, I'd say prior to 2017, if anybody was paying attention, we were putting out maybe about 30 episodes a year. It was really hard for me to keep up. The quality of the episodes was also meh, also. So once I slowed down a little bit, and to be honest, I think I calculated my FTE. My FTE is like, I think it's like point 0.9 actually. It's between point 0.9 and 1. It's
And
just that I do it differently.
for those listening, FTE is a unit of work, right? Like
Yes.
what
Oh yeah.
percentage of a full-time job you're doing, of a full-time
Exactly. So I'm doing about 90% of it at this point. Last year I was about 110, and then the year
job.
before that I was like 130. I didn't even realize it. And that's when like my wife was like, "Look, let's slow down a little bit. You can do what you want to do, but we're not in so much debt that you always have to continue to chase that wheel." So yeah, I hear exactly what you're saying, and I think the key thing about the podcast is, I here's what invariably I think ends up happening is that whether it's on Instagram or social media, some podcasts out there, I think that there's this facade that I think physicians, I think type A people put out there. And I think the goal, and you asked me earlier, what's the mission of the show? The mission of the show is literally to give you a clear window into how the Darkos live and what we think. Initially, when we started the show, it was about let me featuring other people who are doing things outside of the box. That was great. But I think we told that story already. And I literally had like this existential issue of, all right, Renee, what is this show about? Like, we can't just keep telling stories about other people. Like, what is this show about? And she was like, listen, like we are living a non-traditional life. We're the doc outside the box. Why don't we share our journey? Because I think that people will find interest in that. And I was like, what are you talking about? Nobody's gonna want to pay attention to that. And then we started doing the data, and we would look at when we would interview someone else versus when me and Renee, like you said, would talk about issues related to us purchasing a real estate property, us, living 7 months away from each other so we can pay off debt and do IVF, or us going through couples therapy and the downloads were like double. And I was like, huh, hmm. So we just started being very honest with the show and giving people a perspective of this is what a two physician household looks like. We're not saying that you can live, you should do exactly what we're doing, but we're just letting you know that here is an option. And I think it resonates with people. Not everyone, but it resonates with people. And that lets us know that there's a void there that we're filling in. We appreciate that at this point.
Yeah, Nee, I totally agree. And I think when I listen here, and that's kind of what we try to bring out on the podcast. There are, you know, problems that people have or issues that people have. And I've listened to a few interviews, and again, I'm going to kind of jump around a little bit because I have so many things
Yeah,
to ask you.
let's do it.
But
We got
yeah,
time, man.
I love the fact, and I always think it's interesting, and I always think I would have wanted to get an MBA, and I'm going to ask you about that later when, maybe when I was in medical school, and you did that. Is that correct?
Yes. Yeah. Me and my wife did it.
Yeah, so you did the MBA, and then you're doing a podcast talking about how difficult finances are and how difficult insurance and figuring these things out. And you had a problem with an MBA. My question is, are you glad you did the MBA? Do you think the MBA helped you then? And do you think the MBA is helping you now? And if you can go back, would you do it again?
So the MBA helped us do spreadsheets.
Mm.
Um, Oh man. So yeah, so we did an MBA. My MBA program, they're going to be cringing, but it's the truth. So our MBA was great, right? So we did ours in 4 years. It was amazing. It was in healthcare leadership, and we got an experience. And I got it. I was doing my MBA during like that 2003 to 2005, six area. So that was when Medicare Part D was coming out. So a lot of the discussions that were going on in our classroom were really related to Medicare Part D, and it was very interesting, right? And I started realizing I was like, well, I really like marketing. I really like finance. I really like econ. This stuff is really interesting. But what I'm really fascinated is who thought of the donut, for Medicare Part D with this
Right.
pharmaceutical thing. Like that doesn't make any sense to me. And I started, they started teaching us about the history of Medicare and so many different aspects of it, with hospitals and Jim Crow and all these different things. You're just like, this is so fascinating that I found out that I was really more in line with the policy part of the MBA as opposed to like the nuts and bolts, the widgets, how many widgets, how to save money, all the different things that I think someone who's traditionally thinking about getting an MBA or thinks of someone who's getting an MBA, that's the direction that they're going to go. I was going the opposite direction. With that being said, as soon as I finished that, I went straight into a general surgery residency, right? From 2006 to 2011. There was no time for me to do anything MBA related, if you know what I mean. It
Yeah.
doesn't mean that the thoughts were gone, right? It just means that I wasn't, I didn't have time to do that. It's the same thing with someone who goes to an osteopathic medical school and then they go to an allopathic residency, right? There may not be the space during that time to do, osteopathic manipulative techniques. It doesn't mean that you can't think osteopathically, right? Which I think is an issue that people who go to allopathic programs sometimes just like, look, like you may not be able to do all the things that you want to do. It doesn't mean that you can't, you walk away from the principles and you walk away from the philosophy, right? That's a very important difference. And I've always remembered that. So the same thing with the MBA, there was just some things that I've wanted to do, but the technology wasn't there or the time wasn't there. So now we're talking about a good 5 to 6 years. I'm not really using the MBA, but it doesn't mean that I wasn't thinking entrepreneurially or I wasn't thinking about some things that were just kind of outside of clinical medicine that I wanted to do from a business standpoint. But when this is 2013, me and my wife get married finally, and we put our monies together. And I'm like, how come you didn't tell me you had all this debt? And she was like, well, how come you didn't tell me you had all this debt? And I was like, oh, wait, we did go to the same medical school. We did go to the same MBA program. We should have assumed
Right.
that we
Right.
both got the same amount of debt. So I think, to be honest with you, when we got to the point where we tried to figure out how much debt we were in and started doing we started doing Excel spreadsheets. And I'm going to be very honest with you. Like a lot of the things that we learn in our MBA, by the time we are starting to use it when the podcast is starting to make money or we're becoming, entrepreneurial with locums and so forth, I don't remember all of those things. Right. So the question is would I do it again? I don't know. It's hard to say, but it's hard to change all of that stuff because all of that stuff has put Nii Darko here in front of you, right?
Right.
So it's really hard to say. I don't know if I definitely don't regret it. It's just one of those things where when I talk to people who are interested in it, I always say, listen, if you feel like you're going to do something where you're going to use that MBA within residency, then I think it's a great investment. If you think that there's an opportunity that, you may want to take some time off so you can, or some type of sabbatical so that you can work on something related to your MBA, it is a great deal. But just also think that there's an opportunity afterwards when you get out of residency, when you become an attending, to also get your MBA. And that when you do that MBA, the ability for you to start using it immediately, whether it's in your practice or maybe stepping away from medicine, I think is way more useful than when you got it in residency or before residency, and then the possibility of not using it for a significant period of time. So that's the one caveat that I would say. Looking back, I would do it again because it really helped me become who I am. And then, it's not a surprise that, I'm interviewing doctors who are doing things outside of medicine, but they're doing and thriving in business, right? So that's the
Right.
thinking from an entrepreneur standpoint. So it's a tough decision, but I'm looking at the prices now. We're looking at like 75 grand to almost 85 to 100 grand while in medical school. It's tough. Whereas if you're working at a hospital or you're working at a private practice, you might be able to get a significant amount subsidized through that through your work, your employer.
All right, Nee. Again, I told you first of all, thank you for the answer. That's a great answer. And again, a difficult question. Uh, a little non-linear, but my next question is, can you tell us a little bit about the medical missions that you do? Like, there's so much that you do that I want to ask you about, but can you tell us about how you got, like, you're doing so much, first of all. Obviously, you got the podcast, you got your family, you have the locum work that you're doing, but you also find time to do medical missions. How did you get involved in medical missions? And can you tell us a little bit about what you do with that?
Yeah, yeah. So I've been doing medical missions since 2012. My wife has been doing it since 2011. And it started, so she did her residency, her OB residency at UMDNJ, Robert Wood Johnson, which is now Rutgers University. But her attending, Dr. Oh my goodness. Oh my goodness. Anyway, one of her attendings, who's OB, is married to another attending who is OB-GYN, and he's from Ghana. And basically, about at that point in the early 2001, 2002, they both went back to Ghana to spend some time at home. And he was visiting his niece. His niece was pregnant, and they spent time together. Long story short, he flew back to the United States, and shortly afterwards, he found out that she died in childbirth, which is a major issue in third world countries. Definitely, Ghana is one of them. So what he says is that he started doing an investigation and finding out what was going on, and found out there was some things that kind of fell through the cracks. Some balls were dropped, and as he was doing the investigation, some of the people were saying, "Listen, Doc, you left, right? Like you're in the United States because he got all the way to finishing high school, and then he did his college at in the United States. So it's Dr. Ayers and Dr. Akins. So sorry if they're listening, Dr. Ayers and Dr. Akins, and so they were like, "Look, you left," and you know how it is. I don't if anybody's listening who's been to a third world country knows about the brain drains that occur where, oftentimes you train in these countries and you train um, on the state's dime or on the country's dime, and then shortly afterwards, a lot of folks end up leaving and coming either to European countries or going to the United States, and they don't come back. And so he said, okay. So he decided to put his money where his mouth is, and he started this mission trip or humanitarian trip that was mainly for women's health only. And this started in the early 2000s. And then over time and over years, it's expanded to general surgery, pediatrics, internal medicine, anything that you can think of is expanded to that. So by the time my wife went, she was like, yeah, I'm going to Ghana and I'm going to be doing X, Y, and Z. I'm like, wait, you going to my country? Who told you can go to my country? Right. And she's like, I don't need your permission. I can go wherever I want to go. And she had an amazing time. And she told me about it. And I was like, you know what? Next year, I'm going with you. And that first year, which for me was 2012, really changed everything for me. Changed everything because, I get a chance to see so many different aspects of medicine, the positive aspects as well as the negative aspects. Positive aspects of changing people's lives for really not much money at all, right? Like I think the amount of labs that we draw, the amount of antibiotics, pain medications, surgical tools that we use, you just realize like you don't need any of that stuff. What they really need is they really just need more resources. It doesn't necessarily mean tools, just more resources and more docs, right? Or more healthcare professionals. Because these surgeons there are cold. These guys they can operate their way out of anything. It's safe to say that I think that the majority of those surgeons right there, because they have to do everything, are better than most surgeons here because they have to do everything. But long story short, like I left that trip finding out that I learned more from them than I did with them, than I brought in, right? Like, when we brought in our staplers, it was standing room only, right? Like they would just be like, man, this is fascinating. Like these staplers, like cut the surgery in 2 hours or, doing a lap, Coley there, they're just like, this is amazing. What do you mean the patient can go home like today? Like, yeah, the patient can go home today or tomorrow. No, we don't want to do that. Why? well, we just feel like the patient should stay, but the patient can save money and the patient can go back to work earlier. And they're like, oh, we didn't even think about, like, these are things that are just kind of like, but that's not replicatable though over there, right? Because it's expensive, right? And being able to, bring all this laparoscopic equipment and then train the entire staff, that's a very difficult thing. So what I ended up learning is through these humanitarian trips is that, bi-directional education is very important. Sustainability is very important. And there's this savior complex, which is a negative component that I felt like I brought in, where it's like whatever we do in the United States and what we're bringing into this country is the best thing. And it's like I said earlier, a lot of things that you may bring, these are things that it's not replicable. You bring all these staplers, they don't have any replacements for these staplers. You bring some laparoscopic equipment, when it breaks, who's going to fix it? The mesh, they can't just go to Ethicon and say we want more mesh. That's thousands of dollars, right? So these are things that you have to be really cognizant of and realize. Like when I take out an appendix, if it just looks like an inflamed appendix, like taking it out and giving it to the patient to go to pathology, that's going to cost them money. Whereas here in the United States, it's just done, automatically, right? These are things that I'm like, oh, I didn't even think about that, right? Or you'll have patients who will wait hours for you to be, for them to be seen by the doctors from the US. Those are things that you're just like, wow, or I remember, I was in a hospital, and, a patient was in a car accident and they were treating the patient as if they had a spleen injury. And I was like, well, did you get a CT scan on the patient? And they all started laughing at me. They're like, who, there's no CT scans here. But they did an ultrasound. Patient had fluid around the liver. The patient had a Kerr sign, right? So they use their diagnostic skills, their clinical skills that they've learned and we've learned in the textbooks. It's just that they don't have that added resource of getting a CT scan to definitively tell them what to do. That stuff is fascinating. Like they'll diagnose acute appendicitis clinically or just using an ultrasound, and then, you move forward and go there. So it was just a really great experience for me. And since then, I just said that, what, on a yearly basis, outside of the years that, we had children, on a yearly basis, we're going to make sure that we come back and give as much and also receive as much as we can. And, we did an episode recently about that, where we talk about that saviorship and how that can really ruin the trip, and it can really put people um, on a defensive mode, particularly if you come off thinking that, what we do in the Western civilization is just 100 times better than what they're already doing. They're doing great. It's just that they just need more resources. And it's just a very humbling experience for me. It's a humbling experience, I think, for everybody or anybody who comes.
That's awesome. Yeah, I think it's awesome that you do that, and I think it sounds like an awesome experience for a physician to do, and it's something it's on my bucket list. I just gotta find the time, and it's great that you
Yeah.
make the time for that. So, Nee, my next thing that I wanted to talk to you about is just kind of dialing things back and going through sort of your journey. So, can you start off by telling us? You already told us you grew up in New York. Can you tell us about growing up and your parents are not from the United States? Is that
Mhm.
right?
Yeah, they're from Ghana.
So tell us about growing up with parents from Ghana and when you decided, yeah, no, just not, growing up with parents that are, to tell us about that. Tell us about um, when you decided you wanted to be a doctor and where you went to college.
Yeah, yeah. So my dad came here in '68 on a boat from literally he left from Ghana. It took him 3 weeks, and he arrived in Elizabeth, New Jersey at the seaport. And from there, he kind of figured out his way to New York City, worked at a sandwich shop, and had some friends, and figured out a way to get into Bronx Community College, and, got a degree in computer engineering and figured it out, and, just kind of lived this blue collar life. And then my mom came over, in the early '70s, and they just kind of made it happen. And, my two sisters from overseas, from Ghana, came. And then the youngest of the sisters was born here in '74. I was born in '78. And, we were living in near Columbia and up in Fort Washington, New York. And then shortly afterwards, we moved to Queens, New York, in a town called, or a place called Lefrak City, right across from the Van Wyck and right across from Shea Stadium. And so long story short, I remember when the Mets won the '86 championship. Like literally, we were living in an apartment complex, and like people going crazy and all these different things. But growing up in New York City, particularly in Queens, had a really strong imprint on my life. Anybody who grew up in the '80s, I'm sure Dr. Ian. Medical shows were rampant and great. So I grew up watching St. Elsewhere and Denzel Washington and Doogie Howser, any type of medical show, even some of the reruns at the time, Emergency and so forth. But for me, just the concept of a doctor and everything revolving around a doctor was just fascinating. There was nobody in my family at that point who was in healthcare, but I just found it fascinating. I'm living in New York, right across from Shea Stadium. There's the U.S. Open is there, the Yankees, the Knicks, all those different things. None of that stuff mattered to me. I just had to watch these doctor shows that were on. And that kind of laid the foundation for what I really thought of what I wanted to be growing up. And, I would tell everybody, I'm like, I'm going to be a doctor. I'm going to be a doctor. And they're just like, man, get out of here. You're not going to be no doctor. Get out of here. And, once I got into high school and really started to be a serious student, people were like, yeah, maybe you can be a doctor. It's really up to what you want to do. Excuse me, got a little cough.
No worries.
And then once I got into college, I was like, guys, I'm really serious about this. I really want to be a doctor. And the one issue that I had was I wasn't a very, I was the type of person who would isolate myself. And as a result, I didn't spend much time like in the pre-med clubs. I didn't spend much time, being very realistic as to the type of schools that I should be applying to. So I didn't do very well on my MCAT, or at least I did okay on my MCAT. But the schools that I was applying to really weren't on the same page as what my MCAT scores were. I had a very unrealistic view. Long story short, I applied and I didn't get it. And that was very devastating for me because that was really the first pothole that I really hit in my like academic career. Really big pothole. I'm like, well, what am I going to do for 2 years? I don't know what I'm going to do, or for a year. I don't know what to do. And like I said, at the time, when I was applying, my mother was a nurse's aide. That's it. So I didn't have any outside of the people who gave me letters of recommendation. I didn't have any type of in. So I didn't know what to do. So during that year or 2 years, I became a graduate assistant. I was running track during my 4 years at Lehigh. I decided to do graduate assistant work where I would coach, and in exchange for coaching, they would pay for my grad work. And that's how I was like, all right, I'll do some graduate work and I'll get my application stronger and then I'll reapply. And, I really started becoming a lot more strategic with the programs that I was looking at and applying to. And I widened my net. I looked in the Midwest. I looked in the South. I mean, when I was applying the first time, I was like in the Northeast. I'm like, I'm not leaving the Northeast. That's where I'm going to be at. And at the time, I didn't really think about statistics and the how competitive it is. It's just like, they'll pick me. Why? So I just became a lot more realistic, and I got into way more schools the second time, and I ended up going to Kansas City University, which at the time was University of Health Sciences, their osteopathic medical school.
Yeah.
And that was a big deal for me.
Yeah, can you tell us, Nii, when did you find out about osteopathic school, and then how did you choose UHSCOM? And by the way, I interviewed at UHSCOM. I interviewed at UHSCOM, which was UHSCOM when I interviewed there too, and Kirksville. And I was all set to go to the Midwest, and I ended up having a girlfriend that kind of dragged me back to New York. But if it wasn't for her, I would have ended up there too. That's true.
Yeah. So my family doctor growing up was a DO. So I was always familiar with osteopathic medicine. But just kind of, I don't know, it's just part of my DNA, right? Like see DO at the end of your name and stuff. So being able to get that person who can write a letter of recommendation on your behalf was easy for me. But I just had to learn a little bit more about osteopathic medical school. But that was like during the first time that I was applying. So I already knew about that. But unless you are really in depth working with someone who is an osteopathic physician, the whole concept of the philosophies being different, you won't know until you actually go to the school, like you are in school. And, for me, I don't know, it was just a natural fit for me. I don't know why. It was just a natural fit for me. And I really enjoyed it. So for me, it came down to going to medical school in New Jersey, going to medical school in Pennsylvania, or going to medical school in Kansas City, which was UHS. And when I went to go interview there, the number one thing that made me want to go there is they were one of the first, part of the first tier of schools that had this um, systems based curriculum. And for me, I knew that doing the traditional curriculum, i.e., what I did in college, wasn't really working for me. And for me, I just was like, okay, well, maybe this could work for me. Where, if we're going to do neurosurgery, I'll do the anatomy of neurosurgery. I will do the surgery. I'll do the pathophys. I'll do the biochemistry, all of that for that one system. And maybe it'll help me to understand it better. And then the other thing too is they were the first school that literally accepted me. I got home and like within 48 hours I found out. And I had a really long talk with my family and I said, "Look, this school has accepted me." And everybody was like, "This is the school that wants you. Maybe you should go." And I'm like, "But there's nothing outside of New York and New Jersey." And they're like, "Come on." Like I was a typical New York prick,
Yeah.
right? Like let's be honest, right? And I did it and I said, "You know what? Let's do it." And it was by far, outside of marrying my wife, the single most important decision that I ever made. It was the best decision I ever made. Like that for me, the systems based curriculum completely. I became it was just, I don't know. The only other way I can explain is that for me, medical school wasn't a struggle as much as it was in college. I don't know why. Like for me, I just remember like in doing histology for, I think we did histology for, um, I forgot what it was, but literally understand. I was like, oh, this is what an H&E slide is. Oh, this is what the different colors mean. Like I didn't get that understanding when I did it in college. I didn't understand that biochemistry is supposed to teach you what diabetes is. I didn't understand any of that stuff. I didn't understand that there's a link between biochemistry and lactic acidosis and people running track and all. Like these are the things that were like, it was so abstract for me in college that I studied it, but I didn't get it. But once it came into med school, I was like, oh, that's the reason why we have to understand this. Easy. This is easy. I got this. This is no problem. And that for me was, one of the best decisions ever made was going to UHS and now KCU, you know,
Right.
KCUMB and so forth. But yeah, that was the reason why I decided to go there.
Okay, so you had a great experience in I'm sorry. You had a great experience in Kansas City, and then you met Renee there, right? Renee was also a student. Was she the same year as you, or how did you guys meet?
Yes, yes. So actually, we had a mentor who was recruiting for the school, and he put us in connection with each other before school started. So
Oh
we already
wow.
got accepted. We already submitted our what's that, deposits to hold our seats. And literally, Renee grew up in Brooklyn, and I was obviously in Queens, but now I was in New Jersey. But literally 40-mile difference. But as you know, in New York and New Jersey, I mean, it's the most dense area of the United States. But we joke like you never know. We might have been in the same circles at one point, but it's amazing how we never met in the tri-state area, but we met and became really close friends, in Kansas City. And that was part of the reason why I succeeded also, was that I had and came in with, a group of people who I had commonality with. Although I didn't study with them, it was just great to kind of hang out with them on the weekends, or just even, have people to kind of just say, "Hey, look, I'm having a hard time. Can you help me with this section?" Or, "I'm just having a hard time. Can we just watch a movie together?" You know? So that was how I met Renee.
And then you decided you wanted to do surgery. Can you tell us a little bit about how you picked general surgery, how you picked your residency? And then, I know, again, I alluded to this at the beginning. I listened to this week's podcast, and you talked about the fact that the two of you decided not to couples match. Yeah, right. Which I thought was super interesting. So, can you
Yeah.
tell us a little bit about how you picked surgery, how she picked OB and why you decided not to couples match and how you pick your residency.
Yeah, so it's funny. So at age 17, I was getting ready to start Lehigh University. They had this summer program where you can do some pre-matriculation program, kind of get used to being on campus and so forth, take some English classes and things like that. Blah 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 blah. At the end of the program, there was a barbecue, and there was alumni there. And at the barbecue was Dr. Jordan Garrison. He is a trauma surgeon at University Hospital in Newark, New Jersey, which where I was living is a 10-minute bus ride from where I lived. And I pew, ran to him and I was like, "Hey, Dr. Garrison, I want to be a surgeon. I want to be a doctor. Can I shadow you before school starts, right? Remember, this is a pre-matriculation program before the actual year starts." He's like, "Yeah, no problem. Here's my card. Call me and let's set something up." Man, the next like on Monday, I called him up. I said, "Hey, I want to do this," and he said, "Okay, next week, do a night shift with me and blah 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 blah." My parents dropped me off, and he was there waiting for me. Him and my mom and dad, they said pleasantries to each other, and they were gonna pick me up like later on in the night. As soon as they leave, we're walking towards the ER, the ambulance area, and his pager goes off, and he's like, "Listen, I need you to I'm going to bring you into the trauma bay, but I want you to stay in the corner." And there, they have a bunch of yellow gowns and so forth. And I walked in, and it was like, they're like, "Who's this?" And they're like, "This is some volunteer here. Just don't pay attention to him. He's just here to see what's going on." And like 5 minutes later, this guy who was probably maybe seven, I don't know, like in his early 20s, came in screaming and moaning, blood dripping from his chest. And I just remember them turning him sideways, and I can see a little hole in his back and blood dripping down, which was basically a gunshot wound. And he's screaming, and Dr. Garrison is at the foot of the bed, and he's telling people, "You do this, you do that, and this and that." And he's like a maestro, like this is like a chorus. Meanwhile, I'm like freaking out, like, what's going on? And then after like maybe like 10 minutes or so, he's like, "All right, enough of this. We're going upstairs." Obviously, he takes him to the operating room. So, I can't go to the operating room because I'm just there just to watch. But, I'm talking to the residents, I'm talking to some other people. And after like 2 hours, they're like, "Yeah, I think he's out of the operating room." And they took me to where he was, and he was talking to the patient's family. And the mom is like crying, sobbing, but he's holding her and saying that he's going to be all right. He's getting out of surgery, don't worry. And literally at that moment, I was like, that's what I want to do. That is exactly what I want to do. I didn't see what he did in the operating room, but I was like, that is what I want to do.
I have
And
chills,
for the
by the
next,
way. Yeah, that's amazing. That's
yeah,
a great story. Yeah, I have chills.
right. So I went home. I'm like, "Yo, mom, dad, I want to be a trauma surgeon." And they're like, "Okay, cool." That's how my parents are. Like, they're blue collar. They're just like, "Yeah, whatever you want to do. That's cool." And so for the next 4 years, I would just shadow him, go to clinic and all these different things. So I knew in my mind, I was like, I think I want to do surgery. This is what I really want to do. When I started medical school, I made a promise to myself that this, I'm not going to be one of those guys who says, "I'm coming in and I'm going to be a gunner and I'm going to be orthopedic surgery or I'm going to be trauma surgery." I just said, I'm just going to keep an open mind and we'll see what happens. And I literally gave everything an open shot my third year, from pediatrics to OB to to internal medicine. I gave everything a fair shot. When I did surgery, that's when it was like, yeah, this is where I'm supposed to be at. This is it. This is what I like to do. Like, I enjoyed the operating and then literally being excited and waking up the next morning and waiting for the labs and seeing what the patient was going to do. And it really, I didn't know how to verbalize it, but it wasn't until I got into residency and someone said, "The cool thing about surgery is you take something out from someone, and then the next day you get to see how they respond to that. That's a little bit unlike any other field." And I was like, yeah, that's what it is. That's what I really want to do. So, um, so that was a good experience. But what really solidified surgery for me was one of the surgeons, Dr. Durrett, out in the middle of nowhere, Kansas. Like, in order to get to this guy's place, you drive by. Seriously, you are driving past the what is that show? That movie, No Place Like Home. the Wizard of Oz Museum.
Right.
This is how in the middle of Kansas it is. You're going past that point, right?
Right.
So you're going past this area, and it's in a very rural area, Hoisington, Kansas, right? And this was a general surgeon who still did OB or like C sections. This was a general surgeon who did vascular surgery. He was extremely adept in a very, just an old relic unicorn doing, very general surgery. And that's when I knew I was like, this is it. This is for me. This is what I want to do. I love everything else, but I really, really want to do this. And then once I decided I wanted to do surgery, the next step was, well, how's this going to work out? Where am I going to go? And for me, the choices were, am I going to go down the osteopathic route or am I going to go down the allopathic route? And for anybody who remembers back then, the osteopathic match was slightly before the allopathic match. So for me, I was a good student. My board scores were okay. But I knew that I was like, let me be safe and let me apply to both just in case. So I did my interviews at osteopathic residencies and I did my interviews at allopathic residencies. And by the time the match came for osteopathic programs, roughly about 2 weeks before the match came, you probably remember this, Dr.
Yep.
Storch. All of the programs called me up personally and said, listen, we've matched outside of the match and, we didn't match you. And I'm like, oh, snap. That's a problem. So then I was like, okay, so all the programs that I applied to, they're not taking me. What am I going to do? So the only thing I said was I can continue to roll the dice with these allopathic programs. And I ended up doing at the last minute in January of my last year, I ended up doing a surgical critical care fellowship, or excuse me, a critical care fellowship at Morehouse School of Medicine in Atlanta. And um, the goal was they didn't have a surgical critical care fellowship or sub-I. My goal was to go there, wow them so much from a medical standpoint that they would try to introduce me to the surgical guys. So I went there and that's what I did. I was very open and honest. I was like, guys, I really love critical care, but I really want to get into, excuse me, I really need to get into a surgery program. I'm really here to audition. Is that okay for you? I would get there at like 4:45, 5 in the morning. I would leave late. And they were like, look, you're a great worker. We appreciate that, you are doing your best here, but we also know that, you want to try to get into surgery. And they really helped me get an interview with the surgery team. And I knew, or at least I felt that it would be a little bit difficult for me to get into a program that's never taken an osteopathic medical student before. But when my interview came, man, Dr. Ian, yo, I swung for the fences. I did not play. I just said, I'm throwing everything out there. I'm giving them everything. And I swung for the fences. I, said, hey, I came here and I did a fellowship. Or I did a sub-I. I'm dedicated to coming here. Like, if you would have me here, blah, 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 blah. And long story short, I matched there. And that year, 2006, was one of the years where I think every program was fully matched completely. So I was super excited to get in, and I was their first DO resident. And to be honest with you, I walked around with a chip on my shoulder. I was like, oh man, like I'm the only DO person here. That was a chip on my shoulder that I placed on myself. And I want everybody who's listening to this show know that there are a lot of times where you may have some obstacles that are placed in front of you. And there are times when you have some obstacles that you place in front of yourself. And that additional stress was not necessary. There was never any time where anybody said, well, you're here and, you're the only DO student here and we've never taken one before. So you better make sure you put those knots extra tight. You better make sure you write that note so I can really read it. Or I'm sending you right back to the osteopathic. Like, that never happened, right? All of those things that I thought of were all in my head. And yes, it drove me, but that was kind of part of that negative feedback loop that I used to drive myself in a good direction. And to be honest with you, sometimes those things can be hard to turn off, right? those things can be really hard to turn. Like you can graduate and still kind of have that in your mind, and it leads to imposter syndrome, which I'm sure you've talked about on the show, or some of the people have talked about, or it could lead to something a little bit more insidious. So you have to be really careful. That's my advice to anybody. You have to be extremely careful about having chips on your shoulders, particularly if it's not warranted, particularly if nobody else put that chip on your shoulder. If you put it there, it's something that can really be detrimental.
Yeah, neat. I love the story. Your story is spectacular. I love the don't give up, don't take no for an answer, show up to play. I mean, I think we hear that from great DOs again and again, and you echo it, and love it, love it.
Mhm.
But this is the part of the story that I'm so your story is awesome. The part of the story, to be 100% honest, that you don't talk about on any of your podcasts, or I haven't heard you speak about, but I'm super excited about, is that I trained at Jackson Memorial for,
Hey.
yeah, I trained at Jackson. I love Jackson. I feel like anyone that you meet, for the listeners, Jackson Memorial is an inner city hospital in Miami that's kind of, hate to use be crass, but it's badass. Like it's like one of my favorite places. I think it's really helped me be who I am as a physician. And you went to Jackson for trauma. Is that right?
Yeah, yeah, I did.
Yeah. So
Yeah.
tell us about being in Miami for trauma, and how you went from Morehouse to Jackson, and tell us what Jackson's like.
You also didn't say I was in Miami or I was in Jackson when the Heat were when the
I
Heat,
was.
yeah, 2000. It was an amazing time.
Yeah,
So
we had Shaq and D Wade. Were you there when Shaq and D
oh man.
Wade or?
No, no, no. So you had that was a great time for you
Yeah, that's
also.
when I was there. Yeah.
So I was there when the Heatles were there, and it was a great experience. But so yeah, so the experience that you described for Jackson, that's the experience that I had at in Atlanta. So I was at Grady Memorial Hospital, same type of experience. Basically, the way how they told me about Jackson was Jackson is Grady of Florida. And then obviously Grady is Jackson in Atlanta, right? Like kind of very similar large hospitals, like 1,000 bed hospitals that treat mainly indigent populations. But obviously you're going to get like top tier service at these facilities. So when I went to Jackson, it was just kind of like for me like a natural transition. But the biggest thing that was the biggest change was the type of traumas that I was seeing. So in Atlanta, it was knife and gun and MVC club, right? So gunshot wounds, stab wounds, as well as car accidents. But yo, when I went to Miami, oh my goodness, man, they don't play down there. They're like the type of mayhem that was there. Like, whoa, people get set on fire, or I was there when the person got his face chewed off. You remember that?
I
The
do.
bath salts thing that we found out really wasn't bath salts. Um, and the other thing too that was extremely interesting was the Caribbean trauma that we would get, right? So the people who would get injured in other countries who were United States citizens, and obviously they had travel insurance and they would get repatriated back to the United States because they were on a cruise or whatever. Like that type of stuff was amazing. It was just like, and you're reading through the chart, like they did what? Wait, who? They put a chest tube here? No, 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 no. Right? Like it was just very interesting the different type of trauma mechanisms that were there. And I think that that was another big major pivotal point for me, because I think that, and some people may not like to hear this, but I think when you do your trauma, or excuse me, when you do your training at one place and then you also become like an attending there, sometimes you kind of just get stuck in that one way of thinking. And I think in trauma what you end up finding is whatever facility that you're at, or whatever hospital that you're at, like they have their own little system, microcosm of how trauma should be taken care of. And it's amazing. So it was great to get Gradyized, but it was another experience and a great experience to get Jacksonized, to get like that experience of being at that facility and seeing like what these people who wrote textbooks had to say. It was a great experience. It was only for a year, but it was still an amazing experience. The weather was great. you
It's
know, it
great to
was,
live in Miami, right? It's great to live in Miami.
70 degrees in February, you can't beat it. Um, but it was a very different experience. and it was positive. It was really good. And if I could do it again, I would. So
So then again, I'm going to ask you the question that I get asked all the time. So like, all right, Storch, so you lived in Miami for 3 years. Why the hell did you come back to New York? Right? Right? Like
ain't
what
no
made
place
you
like New York. Come on.
yeah, right? Yeah, but like you're living in Miami. So Nee, like what was it did you ever tell Renee like why don't we just settle down here in Miami? Like what do you think of that? Or was it just like your family's in New York, which was kind of my
Yeah.
excuse, so you came back?
Yeah, my family came back. And then also during the year that I was finishing up, my dad got prostate cancer. And I just needed to be back home. It was just one of those things where, what so I'll keep the story short because I know I can talk. So what ended up happening is when I left medical school, when I left for medical school, the plan was go to Kansas City, do 2 years, and then come back and do my third and fourth years in New York and New Jersey areas, and then do residency in New York and New Jersey, and then that's it, right? And just life kind of just kept taking me further and further and further away from New Jersey. So by the time I got to fellowship and was finishing up fellowship, it came to a point where I just kind of knew I was like, I think my parents need me. And then my dad got prostate cancer, and he was very nonchalant about it, which meant that he didn't really understand what was being explained to him. And I was like, Dad, they're saying that you have cancer, right? And he's like, Oh, they didn't say that. And I was like, you know what? It was a low grade one, so he was fine and everything. But I was like, yeah, it's time for me to go back home. And that's when, for me, I was like, yeah, let's go back home. And Renee's families, they live in Long Island now, but obviously that New York and Brooklyn and Long Island is very dear to her. But we just said it's time to come back home. The question is where are we going to come back home? And ultimately, the Northeast was our final destination. The problem is now that we're married and we almost got $900,000 of debt, is living in New York or New Jersey really the smartest thing for us? And that's how we ended up in central Pennsylvania, which was only a 5 hour drive to New York and like a 4.5 hour drive for New Jersey for us. So that was a good compromise for us. So now we live in New Jersey now.
It's great. It's great. So, Nee, I'm going to first of all, you're awesome. And thank you so much for spending all this time with us. I really appreciate it. I'm sure our listeners are going to appreciate it. My final, I have a few final questions, but
Yeah,
uh,
let's do it, man.
yeah. So tell us a little bit about, I think you're like a role model for me as a practicing physician, just as a podcaster and doing humanitarian work and going to Jackson and hopefully being a Heat fan. I don't know if you're a Heat fan, but hopefully you are. No, Knicks.
Knicks, come on, man. Well,
Sorry.
actually, to be honest, so to be really honest, I'm gonna
Yeah,
be honest. I had to give up my nickdom because they're not trying to win, obviously, right? Like for me, I feel like they're trying to win Wall Street. So I just nowadays in basketball, it's really following your favorite player now,
I
whether or
agree.
not
I
that's good or
agree.
bad, they got to work on that. Um, but I mean, look, the Heat are a great stand-up organization anyway. So
I don't know. Live in Miami for 3 years. Got to go with the Heat. But
yeah,
anyway, as a role model to minority students specifically, and I wanted to interview you because I love your podcast, but I spoke to ACOMAS, and I missed you at OMED, but I really wanted to talk to you
yeah.
at OMED also. Can you tell us a little bit about how important it is to be a role model, and how you what you think the importance is of what you do, specifically being a role model to all students and specifically to minority students.
Yeah, I mean, look, the reason why I became a doctor is because I had TV role models, right? And eventually, I had some clinicians who became role models for me. And I do believe in the notion of if you don't see it, then how can you really emulate it or be it? I think that's extremely important when you're struggling through biochemistry as a college student, or, histology, and you can't see yourself, at the finish line, which usually looks like somebody else who's just looked like you maybe in that situation. It's hard to keep going. And whether or not they know it or don't know it, it's important to have that. So for me, to be honest, when I started this process and started this podcast, I never really set out to be a role model. I just said, you know what, I'll just kind of live my truth and kind of speak my truth on the show and just kind of go from there. I think invariably now, because I'm 10 years in now, people will look and say, okay, like Doc, like I see your life, or I see your career, or I see this mistake that you talk about, or I see how you paid off debt, or I see this, and I want to do that with my life. That really means a lot to me because 5 years ago, I really wasn't trying to share that information. I thought that nobody thought that it was important. So for me, to be able to, know that I kind of put a chink in the armor of, the thought process that people think that doctors are infallible or doctors make mistakes or doctors know everything about money, that's really important to me. In terms of, being a role model for minorities, it's a complicated uh, 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 answer because I'll tell you, like I me and Renee speak our truth, right? And I think that what we talk about, our experience that we talk about, obviously, is from people who grew up in Queens, people who grew up in Brooklyn, people who are from an immigrant background. But it also just happens to be that we're black, right? And the reason why I say it like that is that if you listen to our messages, whether you are black or you are white or you are Asian or you are Hispanic or you are Native American, we wholeheartedly believe that the message and the issues that we're talking about apply to you. And we're very careful to just kind of not make sure that we don't qualify what we're talking about, because I think oftentimes when you qualify things, people tune out, right? So if you say, oh, from my black perspective, people are gonna be like, oh, I don't want to hear that. So we always just say it's my perspective, and it's true. Like, my perspective is part of the American fabric of the United States, right? It just so happened that I was raised in Queens, New York, and Lafrac City, and grew across the street from Shea Stadium, and like it's just, so for me, we speak our truth and we just talk it, and whoever wants to ride along and listen to the story, cool, you're part of our tribe. But I do think that, yeah, there's other African Americans and there's other minorities who are underrepresented who may say, look, like, I see what they're doing and I want to attach myself to something like that. That means a lot. That means a lot. And I also hope that there are people who listen to our story who are not from our backgrounds and say, you know what? Yeah, I rock with them. And I really like their story also. And it happens to be a perspective that maybe I didn't grow up with. But ultimately, this story is central to every doctor's life, which is, hey, I wanted to be a doctor because I wanted to change my station in life. And it just so happened I didn't have anybody in my family who was a doctor. And now that I became a doctor, I found that I was broke. I still love medicine, but I got to figure out how to not be broke, and I got to figure out how to make this work. And if you guys want to come along and listen, let's do it. Come and listen to me weekly. So that's kind of the perspective that we have on this show.
Yeah, no, Nee, again, I think your honesty is amazing. And it's interesting, just as an aside, there's one podcast interview that I listened to where a woman was interviewing you, and she kept focusing on the fact that you and Renee were both doctors and had this high income potential. But you were trying to say, look, but we have like $1 million in debt, and this is
Yeah.
very stressful coming out. And I think you're very honest about that. And for people that don't go through the journey, it's hard to really understand how hard that is. And you make it very clear.
So in that point, when you're saying that, the reason why we were trying to say that is because, remember when you asked that question about getting an MBA
Yes.
and what aspects did it help with, and you recognize that, okay, they got their MBAs, but they still can't get themselves out of debt. There's a
Yeah.
problem here, right?
Yes.
We ended up learning how to pay off our debt from people who were making less than six figures, right? Those are the people who we were listening to their podcasts. So the overall and the overarching theme is you never know who you're going to learn something from, right? They literally, like, we were literally learning how to pay off our debt from folks who were principals in school, people who, were stay-at-home moms. The principles are the same. It's just that their voice is something that maybe, I haven't heard a perspective from, but the ultimate concept of live within your means is something that, whatever background you come from, whatever it is that you're doing in life, that message is the same, right?
Universal, right? I
And
agree.
right, it's
Yeah.
universal. Or just, in some regards, saying that, you know what, there's some things that I may want to do with my career, and I may just want to walk away from, doing something where I'm employed, maybe if we pay off our debt, like these are the type of things that we were kind of listening to. And we're like, oh, we didn't think about this. But also understanding that there's certain sacrifices that we're going to have to accept. And that's where, just like what you said, like that person was trying to say, yeah, I mean, like, yeah, but you guys are making a significant amount of money. So the debt's not that big of a deal. It's like, oh, yeah, really? Like, we don't want to live 5 hours away from home. Like, or we don't want to be spending $200 a month on groceries for like, there's a reason why we're doing it. It's debt is a pain in the ass. We don't want this a part of our lives.
Right.
So,
So, Nee, again, thank you again. My last grand finale question that we kind of throw to everyone that we have on the show is, can you give us one piece of advice that you were given by somebody else that you feel has really been influential to you that you would like to pass on to our listeners?
oh yeah, I think the number one thing is whenever you help, whenever you help someone, always give knowing that if you're going to help that person, that hopefully their thanks will be not in you getting any thanks back or you getting like a response back, but them helping somebody else out, right? Almost like the whole notion of just pay it forward.
Love it.
And I've looked at that in terms of my clinical training when at Morehouse. Like there's this legacy, right? Someone trained this surgeon who's training me, and now I'm training medical students and so forth. And then even from the podcast, right? Like I never try to get anything back in return. It's just like, look, this is our story. I hope you learned something from it. Don't make the same mistakes that we make. But yeah, that's the advice that I would give to the audience is just literally give without thinking that you're going to get something back. Always, whoever you're helping out, just say, listen, the only thanks I want is that you see someone who may come from my background or may come from my disposition, help that person out without asking. So
I got it. Nee, again, thank you. Thank you for your time tonight. I really enjoyed our conversation, and you're absolutely awesome.
thank you, Ian. This was great. This was fun. You're excellent at interviewing. So I really appreciate your time.